Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a very complex case of a patient who attended with bilateral blocked ears, and it was their left ear in particular that they were really struggling from. This is their left ear. And just to give you a backstory now, this patient's sister, who also attended, is a big fan of mine, and she's been trying to convince her sister to come and visit me for a while, I think now. And the patient has had chronic ear infections, ear pain, reduced hearing, and they've been to see their doctor several times. And in the past, they've been prescribed some topical antibiotic spray called Oadby. And although the patient found that the Oadby helped reduce the inflammation that this patient constantly experiences and suffers from, they still felt their ear to be infected, and obviously you can see all this discharge and debris that's contained and accumulating within their ear canal. So based on that knowledge, and also the fact the patient is a very keen swimmer, and although they do wear ear protection, I'm already believing this patient is suffering from otomycosis, a fungal ear infection, and I'll explain the reasons for that in a bit more detail. So the Oadby topical antibiotic spray contains 3 active ingredients. The first is dexamethasone, which is a steroid, which is anti-inflammatory, which the patient felt was working. It also contains acetic acid, so the acidity just helps to reacidify the ear. When our ears are naturally acidic, between 5.4 and 7 on the pH scale. And quite often when they're infected, when you've got an outer ear infection, so otitis externa, which is what this falls under, the ear pH increases, it becomes slightly more alkaline. So if you re-acidify the ear by introducing some acetic acid, it just helps the ear return to its natural and normal pH, which can sometimes help to inhibit harmful bacterial and fungal growth. However, Oadby also contains an antibiotic, neomycin, and if this is a fungal infection, that antibiotic is not going to do anything, and in fact it can make it worse, because the neomycin actually fights away some healthy bacteria in the ear, which then means that the fungus has got no competition. It's free to reign, it's free to colonize, it's free to reproduce and exponentially grow. And I feel this patient has got some candida, which is a strain of fungal infection. The reason why I suspect that is because this is quite thick and creamy discharge. More typically, with a bacterial infection, the discharge is more less viscous, it's more purulent, it's more, it's a bit more runny, a bit more less sticky and gooey like this. And I also think there's some fungal spores as well, so there could be some aspergillus, either Niger or flavis contained, so I think there's probably multiple strains. So the idea is to remove as much of this debris as possible. The eardrum is actually visible, believe it or not, it's there. I've removed the occluding debris, but this thick creamy discharge is coating the eardrum. It's probably the most difficult type of debris to remove because it is so gooey and sticky. But we're going to try our best to remove as much as we can to reveal the eardrum, but also because it will then help any medication this patient is going to be prescribed by their GP to really make contact with the canal wall and eardrum and be most effective. So I've written to this patient's GP already, and I've requested that the patient undergo a swab of the ear to really ascertain exactly what's going on, whether it's a bacterial or fungi, or a bit of both maybe, prior to being prescribed the appropriate medication. It's just because if they are again prescribed antibiotics, so this is a fungal infection, it's just going to make the situation worse. In the meantime, I've just recommended the patient to use some over-the-counter acetic acid spray for the ear, just to help to reacidify the ear. And I've also recommended that they avoid swimming until this infection's cleared. So this patient's been suffering for several years. Upon attending, they were really struggling to hear. And because this patient suffered some psoriasis, itchiness, what the patient was experiencing during the procedures, whilst I was cleaning the ear, they were developing itches in other parts of their body, which sometimes made it very difficult for the patient to remain still, but they did brilliantly well. I always had one eye on the patient, so I was looking out for any sudden movements. It can happen. The first real case when I came across that was of my young nephew. He's about 12 and was cleaning his ears out, and he developed such an itch on his knee, so some sort of obviously involuntary response, that he constantly felt the need to scratch his ear, which would mean his body would move and his head would move. Ironically, I use a derma roller on my scalp, so I'm trying to prevent myself from going completely bald. So a derma roller, I use it on my scalp, I develop a runny nose and I get watery eyes. So again, there's some nerves being initiated just by rolling the derma roller on my scalp for me to experience these other kind of almost side effects. But the patient did brilliantly well. She did really, really fantastically well. So the procedure is made complex not only by the consistency, you can just see some of the eardrums now revealed. You can see that blue-purple tinge, and this gunk is just laid over it. Now, I've had to use some drops. I was trying to avoid the drops because obviously there is possibly some fungi in here. I've resisted the urge to use any olive oil because I was reading on one of our audiological papers written by an ENT surgeon that if someone's got a fungal infection, it's best to avoid olive oil because that can exponentially make the infection worse because the fungi actually feed off the oil. So I just use some sodium bicarbonate drops. Now, sodium bicarbonate, yeah, it has got some water base in there, but it has got some antiseptic properties as well. It's just weighing up the pros and cons. So we just put some drops in, just as much as we needed, and I vacuumed it immediately, and obviously we're going to re-acidify the ear straight afterwards. Of course, this patient should not undergo ear irrigation in any circumstances because this is classified as otitis externa. So when a patient has got otitis externa, they definitely should not go under active ear irrigation or, again, avoid going swimming and other water activities. So what I'm trying to do here is peel away this thick, creamy discharge and dead skin. So again, it's quite common with fungal infections. Patients experience extreme psoriasis, itchiness of the ear. If you wait till the end, the patients sent a reply email because I forwarded a copy of the letter that we are posting to their GP, and it's a lovely letter. And on that, the patient also makes reference to their sister, who's a big fan, and the sister was great. I think she said she's watched almost 1,400 of my videos now, and she's so fascinated to see it in person because she's only seen the videos. And the patient, the sister stood behind me and asked whether it was okay to film, which I said it was no problem whatsoever. And it was quite nice because they had so many questions based on the videos which I could answer and clarify. And one of the things the patient sister said is that on screen these instruments look so big, but in reality, because they're in front of her, just how small and minute they are. So yeah, with an endoscope, it is magnifying everything tenfold almost. So in reality, this patient's ear canal, if we were to measure it, it's quite a narrow ear canal. They have got a bit of edema, so a bit of swelling. I would probably say the width is about 0.4, 0.5 millimeters in diameter. So it's extremely narrow in width. And the height, as you can see, it is designed to be oval in shape, so the height is greater than the width. So I would probably say about 0.7, 0.8 millimeters, which gives us very little wriggle room to work inside the ear. So what I'm trying to do here is just peel away some of this creamy gunk from the roof of the ear canal, from the attic region. One of the other difficulties, you can just see it there, was having to constantly come out the ear and unblock the suction probe. I'm using the fine end suction probe here because we're working very deep in the ear. and because the patient's got a narrow ear canal as well. And this consistency of debris keeps blocking the tube, so when I'm suctioning, it gets trapped inside, so I'm having to come out and use a little threader that we have to sieve it through and feed it through to clear any blockages. So again, we're going to be really careful. We are working directly on the eardrum. The eardrum is around 0.1, 0.2 millimeters in thickness, so it's wafer thin, like a sheet of paper, probably a bit thinner. So because we're working with sharp objects, we're just going to be careful, because one false move, I could quite easily rupture the patient's eardrum. And as I mentioned earlier, the patient was experiencing some itchiness, other parts of their body, which was causing them to somewhat move on occasions, although they were managing it really well. Just peeling away from the front part of the ear canal. For me, this is the most sensitive part of the ear. So the inner 2/3, for anyone new to the channel, the inner 2/3 is very, very sensitive. It's made up of bone, and we've got the thinnest layer of skin, 0.1, 0.2 millimeters in thickness, lining the bone. So if you make contact with that, the best, probably the thing I can compare it to, is if you've got an exposed nerve due to a bit of a tooth infection, when you have some cold ice cream or really ice cold drink, that stinging reaction you get, it's extremely painful, and that's what it feels like if you bump into the bone with a bit of force. I know that myself, because I've experienced some trauma into my ear before, so which in a way makes me well versed when I'm performing the procedure, because I can appreciate what a patient can feel if I do make some real bad contact with the bony part of the ear canal. So, and for me, just the front part of the ear canal is a bit more sensitive, probably because it's got a bit more blood supply there, so probably a few more neurons there as well. So it just makes it a bit more sensitive. Just trying to steady my hands. Just trying to peel it away off the eardrum. I think I eventually do get that, but it's just a bit of a tedious part. Now, of course, I could have probably left this. The patient could hear really, really well already, but as mentioned before, because this has probably been there for a long, long, long time, and I just wanted to get as much out as possible, as safely as possible. So you'll see in the right side, there's a point where when I finished, I could see the majority of the eardrum, probably on par with this, but I wasn't going to get any more out. It was a bit more stubborn on the right side, so I decided that's the right time. I made that clinical judgment to leave it. But whenever I feel I can, especially in cases of infections, purely so it allows any ointment that the patient prescribed to make direct contact with the eardrum or the ear canal, so it's the treatment that they receive is most efficient. So I'm just going to go to the bottom. This is the inferior portion of the ear canal and the eardrum. You can see with suctioning it's just not coming away. So it's like thick, wet mud. But in a moment, it's peeling away. Now again, I don't know how thick this layer is, so we've got to be careful with the suction probe. I don't want to embed it too deep, because we could very easily graze the floor of the ear canal and also the eardrum, causing more trauma. And when we cause more trauma, that's the last thing we want, because that's going to make the infection worse. If we start cutting up, bruising the ear canal, the fungi or bacteria, whatever is going on here, can enter those cuts and abrasions and penetrate deeper into the ear and make the infection worse. So just trying to lift this away, and I think it's starting to peel. So I'm probably less than 0.1 or 2 mil away from the eardrum. In a minute, we are going to directly work on the eardrum. And on the right side, I was on the eardrum for quite a while, actually, because it was a lot more stubborn. Now, in terms of fungal infections, they're probably they are less common than bacterial infections in the ear. Bacterial infections account for more or less, I think the statistics suggest 80% of ear infections. So the remaining 20 are fungi, and the most common types of fungal infections are aspergillosis. So aspergillosis, they're normally easy to diagnose and recognize. You get hyphae, so these woolly strands, and you get fungal spores. They could be black, white, or yellow in appearance, or green. And then you get candida. So aspergillosis is probably three-fifths of all fungal infections, and the other 2/5 are candida. So that's a bit more difficult to diagnose, but they are more thick and creamy, which makes me suggest this patient may have a combination, because some of it is thick and creamy and they also have got some fungal spores. So this layer of dead infected skin, just peeling it off the eardrum. So that was quite a significant piece. See just how much cleaner already the ear looks compared to when the patient attended. And fungal infections are most common in warm, humid conditions. So when you go swimming, that can obviously introduce moisture, humidity, but a lot of people that go swimming can also develop swimmers there, because more generally bacterial. But the fact that this patient's also got really dry skin on other parts of their body as well. I think it was the bowl of the ear, the outer bowl, we call it the concha bowl. They had really dry skin there. Today, when the patient attended on that particular day, which was on Friday, it was visible just how dry and tight and constricted the skin was. But that patient advised that was a good day. And they also have really dry, tightened skin behind the pinna, so behind the cartilage of the outer part of the ear. And also they have it in the pit between the on the underneath of their elbow, where your lower arm and upper arm meet. So they have really dry skin there. So it's just that the anterior superior region, so the northwest region here we're working on. Again, this is a difficult region to access, especially in the left ear if you're a right-handed person. You've got to ensure you stretch the ear open with the endoscope and then insert with the instrument to gain access in here. Otherwise, your hands will cross over, so it can be very difficult. Just see how dry and thick this part is, actually, and just peeling downwards. Trying to get this off the eardrum. Now, this patient had to return later on in the day, so our appointments are allocated for half an hour. Half an hour is for 99.9% of the appointments more than adequate enough time. In fact, most procedures I perform completed within 3 or 4 minutes per ear. But I do allocate myself half an hour, because you just don't know until the patient arrives what's going to be complex and what's not. And we are seeing a lot more complex cases now from people around the UK. A lot of colleagues refer complex cases to myself. So we do allocate the half an hour just in case, although often it's not required. But in this case, half an hour wasn't actually enough. And I completed the left ear in the half an hour, and then I commenced with the right side, and I was working on it for 10 minutes. And then there's a point in the right ear after removing the initial plug that I realised that is going to be equally as time consuming, and we had patients already waiting outside, and I didn't want to rush. So left ear done. This is the patient's right ear. And so the patient attended near the end of the day, and I just asked them if they were happy just to wait until after the clinic. And they're more than willing to do that, which is great, 'cause you just don't want to rush it. It is quite a delicate procedure when we're taking stuff off the canal wall and directly off the eardrum. So although we're in 19 minutes, but those bits that I had to kept coming out, cleaning the inside of the suction probe, putting the drops in, so it was half an hour in total in real time. So the right side, I was hoping initially it wouldn't be as bad, because they did say their left ear was the worst of the two, but in fact it ended up being a bit more complicated. So The zonular suction probe that we're using, the diameter is 2.1 millimeters. You can see that just about fits. So it's got a very narrow ear canal, slightly inflamed on this side, a bit more redder than the other side. And of course there's a lot of edema, swelling. And this is the point where I felt, yeah, we're going to have to get this patient back, because just tell how creamy and thick it was. It's going to be a bit of a tough job to remove. And just going to the back part of the ear canal, peeling inwards, trying to get as much of this skin off and debris off in one movement, in segment. Okay, so I think this is when the patient returned. When they did return, they were already saying how much better they could hear. So it really made a big difference. And it has been affecting her quality of life. As mentioned, that her son lives in Canada. It's been difficult to speak to her son on the phone. The TV volume's extremely loud. It's just generally people are finding it difficult to converse with the patient. So we're discussing long-term plans, because in my experience anyway, when a patient comes with a condition like this, it is generally chronic, and it's just about maintaining it. So once this initial infection's cleared, the patient is a keen swimmer. Obviously we wanted to continue swimming, so just discuss some water protection. They go swimming. There's probably some custom swim plugs, so they're custom made for the ear, so it prevents any water from entering. Acetic acid spray to help recidify the ear. And if it is a fungal infection, I'm going to advise that they don't use any olive oil, because that will potentially exacerbate their symptoms. So the patient's going to keep me up to date with regards to what they've been diagnosed with, and then we can come up with a good plan. They are, in my opinion, also going to need regular cleaning of the ears. So, and this has been several years. So we've said about a year, and then we'll monitor it from thereafter. Obviously, they may need to attend before the year. So we're working directly on the eardrum. Again, I think this is candida. It's a fungal infection. There is possibly a few spores embedded. So there might be some aspergillosis, and it's like sticky tape on the eardrum on this side. So it's just some skin that I'm peeling towards the eardrum. Sometimes when you do that, the skin starts to then peel off the eardrum, and you can get it off in one piece, but it's just separated as we approach the eardrum. And here I'm literally gliding on the eardrum, so the patient did so well. I was, again, worried in case they make any sudden head movements, but they were great. What the patient said they did is in the interval, because they were worried about moving, and they were developing the itch on their forearms, so they just used some rubbing alcohol and rubbed it on the areas that they're feeling it was itching. It really helped the patient. So we're just working on the roof of the ear canal, on the superior aspect of the eardrum, so the attic, and also in the anterior recess. To the right, there's a little widening of the ear canal, and we call that the anterior recess. So as we approach the eardrum, the ear canal narrows inwards, and then about 0.5 centimetre away from the eardrum, the ear canal it protrudes outwards again. So that creates a couple of recesses, one inferiorly at the bottom of the eardrum and ear canal, called the inferior recess. There's a little recess there, and one to the front of the ear canal. We call that the anterior recess. And it's without an endoscope, it's very difficult to visualize the anterior and inferior recesses also. So that's where the endoscope comes in its own. Because of the wide panoramic field of view it provides, we can see parts of the ear that it's not possible with a microscope or an otoscope. So as an audiologist, but during our training years, we never used an endoscope. And when I started to use an endoscope, I think back in 2015, it really changed the way I was able to diagnose patient with different conditions. It just increased my knowledge tenfold because I was able to see things that I wasn't able to previously, and therefore give a better diagnosis. So the back part of the eardrum is more visible, but we've still got all this gunk at the floor of the eardrum and also anteriorly. And just in comparison to the left side, the ear canal is a bit more puffed up, it's a bit more inflamed, a bit more swollen. Yeah, the frustrating part about this procedure, it's just the suction probe just getting blocked. As you can see, I'm going to go in and out multiple times. So just put a bit more drops in just to help. But already the patient could hear really, really well on this side. And the whole ear canal's clear, it's just on the eardrum now. So I'm just being a bit cautious because I just don't know how thick this layer is. And again, as I advised earlier, the eardrum is wafer thin. It's a lot of tensile strength though, despite its thinness. But again, any sharp instrument can quite easily penetrate through the eardrum. So the eardrum is made up of 3 layers. The outermost layer, that's visible to us, is made up of the same skin that lines the inner 2/3 of the ear canal. So it's the epidermis skin. More specifically, we call that stratified, which means layers. Squamous, which means skin cells that are aligned like fish scales or like pancakes, they're flattened. Keratinous, so the skin, as it dies, it produces the protein keratin. Epithelial, so they're the outermost type of skin cells. So we call it together collectively, the outer layer of the eardrum is made up of stratified, squamous, keratinous, epithelial tissue or cells. Then you've got the inner membrane of the eardrum, which is not visible to us, and that's made up of a mucosa layer of skin. So the mucosa, it's similar to the skin that's lining the inside of our nose, so it's more secretory, more wet, more moist. Mucosal skin shouldn't produce keratin. And then you've got the middle membrane, which is made up of fibrous tissue. So the fibrous tissue and the main body of the eardrum is radially aligned and concentrically aligned, which gives the eardrum its strength and rigidity. On the top part of the eardrum, pars flaccida, the fibrous tissue is more diffuse. So it's the thinner part of the eardrum, it's not strong. Hence why we call the top part of the eardrum the pars flaccida, so it's more flaccid, and the main body of the eardrum, the pars tensa, because it's got a lot more strength. And just see how thick and creamy this is. So all the residual stuff is actually just staining when you've got wet wax. And I showed the patient on the tissue with some of the debris. See, because it's wet and gooey as you're pulling along, it's just staining the eardrum. So it just wasn't possible removing everything. But I've got the main debris out, which is the key. You can see how I've just curled and bent the end of the fine end. And that just helps me to avoid the front part of the ear canal. I mentioned when I was performing the procedure in the left ear, the front part of the ear canal for me is the most sensitive. So I don't want to make contact with that. So by curling the end of the fine end, we're almost, as I said, bending around the front part of the ear canal so that you can get access. Without that bend, I would be grazing that front part of the ear canal. Once more, I was hoping for it to suction up, but it didn't. It just blocked the end of the fine end. So I think this is the last bout of drops. So we're just going to make contact with the eardrum. Here we're literally gliding. I'm making cotton, kissing the surface of the eardrum, and I'm moving my suction probe up. Yeah, we're just, at the same time, I'm just getting my endoscope further and further in the ear so I can get a better view, more zoomed in, close-up view. So we've got a nice piece out there. This is the umbo. You can see it's this bit is actually attached to the eardrum, but I managed to peel it away. So the umbo is where the hammer bone, which is the first of the 3 middle ear bones, is attached to the eardrum on the underneath side. So it's almost like the bullseye of the eardrum. That's what I always compare it to. Just the centre of the eardrum. And there's just a bit anteriorly here, you can see, just trying to get the view, stretching the ear open, trying to peel away. And see some of it's being suctioned, so it's a bit clearer. So working near the pars tensor here, we'd be very gentle. And this is the top part of the hammer bone. We call it the short process. Again, we'd be very gentle. So I'm just trying to peel it. I'm not sure if I managed to get that, but again, I'm very pleased with what we've done already. Some people may not be, so I'm expecting possibly some emails. Yeah, can you just imagine that some people actually email me and have a bit of a go at me for leaving bits and bobs? So we shall see the inbox tomorrow. It's quite amusing actually when that happens. I think I actually just bent the fine end a bit more, so at this point, so I can really get deeper into the ear. I think I'm more or less done. Let's have a look. Might have one more attempt. Just going to the ear, straightening it up. I think we're happy with that. I don't get any more out without causing trauma to the eardrum, so we'll have to weigh the pros and cons. This is the email response. I emailed the patient a copy of their referral letter, so it's nice for them to reply back. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.